Hello everyone, I am Dr. Anvi Vaidia here at the Henry W. Block School of Management. We are filming our Well Talks here with Amber Chitwood today, who is a respiratory therapist. So let's talk to Amber today about hypoxia. Hi Amber, how are you?
I am very good. How about you?
Great, thank you. Why don't you start with an introduction of yourself?
I have been a respiratory therapist for 9 years now. I primarily focus in critical care, and I'm currently a float RT.
That is great. What is a float RT, just for knowledge?
I can go to any of our ICUs, save the NICU for the babies. Those are different RTs, but floor therapy, the emergency room, and any of the ICUs.
That is great. So today we are talking about hypoxia. Would you like to define hypoxia or explain hypoxia to everybody here?
Sure. Hypoxia occurs when the cells and the tissues are not being adequately supplied with oxygen. That happens in several different factors, but some examples are pulmonary embolism, pneumonia, and COPD.
How do we figure out that somebody has hypoxia? Are there any signs or symptoms or something that a provider should look for?
There are signs and symptoms. Sometimes the first signs are cyanosis. Some patients may turn a blue shade. They may have shortness of breath or have a low tolerance for physical activity. It can be monitored invasively or non-invasively. It's usually first discovered non-invasively by an SpO2 of less than 90%. And then it often is also more observed in arterial O2 of less than 80.
Okay, so let's talk a little bit about, are there different grades of hypoxia? Like you mentioned cyanosis. Is it a generalized cyanosis? Is it seen in some specific areas? How would you look for cyanosis?
It can go throughout the whole body, but it usually starts in the fingertips. If it gets to that point, you probably know your patient needs to be assessed for something. So it normally doesn't get that far before we're intervening in some way.
Oh, okay. Let's again talk a little bit about the oxygen delivery systems, the different kinds of oxygen delivery systems. And I see that you've brought some stuff here that you can talk about and demonstrate to us.
So first line is just our basic nasal cannula. This one has an end-tidal CO2 monitor, so they normally don't necessarily look like they have this part. But the nasal prongs go into the nose. And this runs 1 to 6 liters per minute and delivers about 24 to 44% FiO2. That's first line. If you find your patient needs more than 6 liters per minute, their sats and oxygenations just still aren't quite good enough. This is a high flow nasal cannula. Works the same, prongs still set in the nose, but the tubing for this is larger bore, and so it can tolerate and deliver higher flow rates. It can go up to 15 liters per minute. Still yet, if you are struggling with maintaining your patient's oxygen status, this is what we call the oxy mask. It's great for patients who are primarily breathing through their mouth as it goes over the nose and the mouth. And it has a handy chart that shows you the flow rate setting correlated to the delivered FiO2. And then next is the non-rebreather mask, which many providers are familiar with. It is commonly referred to as a 100% non-rebreather mask, but I should say it doesn't quite hold up to those standards. It delivers more like 60 to 80%. And that's because there's no way for us to tighten this elastic strap and the flimsy plastic tight enough to prevent the entrainment of room air. So 60 to 80% rather than 100. And lastly, we have this newer device, which looks similar to that traditional nasal cannula we talked about with prongs that sit in the nose. However, this is connected to a mechanically driven machine, and it can deliver flow rates up to 60 liters per minute, which is significantly more than any of these can do. And those are good for those patients who are very labored, they're tachypnic, and they're air hungry.
Okay, that is wonderful. You also talked about non-invasive and invasive mechanical ventilation. Could you elaborate a little bit?
So non-invasive mechanical ventilation involves a mask that sits on the patient's face. It's tightly strapped down around the back of the head and connected to a machine that we deliver. We can do 3 different modes with. First mode would be what we call CPAP. It is delivering a PEEP, which is positive end expiratory pressure, and it's a setting that can splint soft palate obstructions or recruit alveoli that are atelectatic. It's good for oxygenation. The next option is BiPAP, and as it sounds, bi, it's 2 pressures. One is the PEEP, just like in CPAP, so it helps with oxygenation. And the second is a driving pressure that helps move air into the lungs and out, and it helps with ventilation. And then lastly, we use AVAPS mode, which is a play on the BiPAP mode, as well as what we use in traditional invasive ventilation. We set a respiratory rate, we set a tidal volume, and we set a PEEP, an FiO2, and that tidal volume is guaranteed by a pressure setting that varies with each breath, but it makes sure that we target that tidal volume each and every time.
So for the benefit of our viewers today, can you talk about the indications of invasive versus non-invasive? Are there any indications?
So we want to start with non-invasive if possible, but those patients have to be conscious and they have to be able to protect their airway. If they're not conscious enough, then we just move straight to invasive ventilation.
Great, great. That was some excellent information. Thank you very much, Amber. We really appreciate your time here today, and we appreciate all the information that you've given out to me and our viewers here for Well Talks. Thank you very much for your time again, and thank you to the Henry W. Block School of Management for letting us film here. Thank you very much.